So now we are going to listen to Mr. Bin Lin. So Bin Lin is an infectious diseases and critical care pharmacist from China. So he will be delivering a topic on therapeutic drug monitoring of antibiotics in China. So Bin is engaged in clinical practice and scientific research, particularly on therapeutic drug monitoring. His research interest focuses on individualized application of antibiotics in critically ill patients. Bin is an executive member of the regional Asia Pacific section of IATDMCT, and he is committed to promoting cooperation in TDM between China and other countries and regions. And I'm quite fortunate to be able to discuss with Bin Lin on the prospect of China being involved in the DALI 2 study, which is going to be a huge study.
Hello, everyone. I'm Bin Lin from China. I'm a critical ill pharmacist, also the director of the pharmacy department. I'm very interested in applying TDM to critical ill patients. I'm honored to have an opportunity to share with you about the topic TDM of antibiotics in China. Okay, first of all, I declare that I have no conflict of interest. Okay, today's contains has three parts. Firstly, I will shortly introduce my hospital and about difference between China and Australia, about TDM level and pharmacy department. Secondly, we will discuss about development of antibiotics TDM in China. And finally, I will share two cases about using the TDM. Okay, my hospital is affiliated hospital of Zhejiang University, is a tertiary teaching hospital founded in 3040s. It is the largest comprehensive hospital in local area. There are 46 departments, 26 wards, and more than 1,000 beds. This is our hospital. And our pharmacy department, we have 90 pharmacists, but just 14 clinical pharmacists and other 76 dispensing pharmacists. It's different from the Australian because we have large outpatient pharmacy. The number of prescriptions are huge in outpatient pharmacy, about 3,600 prescriptions per day. We have massive PWAS. This PWAS is very huge. The infusion will makes the 2,006 bags of daily infusion preparation. Clinical pharmacy work in China only began at the end of the 20th century, and our clinical pharmacist can only cover a few departments, but always increase. Clinical pharmacy lab is especially work in our hospital because clinical pharmacy lab will provide TDM survey rather than in pathology department. This is our ICU wards. In ICU wards in our hospital, a totally of 18 birds in the ICU wards. About include the January ICU is a mixed the ICU is the biggest ICU in our hospital. There are 45 birds and some specialized ICU like emergency ICU and the CCU and the respiratory ICU and NICU and the pediatric ICU. Our ICU pharmacist conduct daily rounders with medical teams. Our ICU can carry out the ECMO, IBP, CRRT, and ECCO2 therapy. The ICU will treat critical ER patients such as sepsis, severe abdominal infection, and trauma. This is our clinical pharmacist team. Our clinical pharmacist team include infectious disease, critical care, oncology, clinical respiratory disease, and so on. All clinical pharmacists have obtained the National Health Committee clinical pharmacist qualification certification. This is our bioanalyze co-leader, Dr. Sun Liang. This is a clinical research leader, Wei Bingfan. He is also oncology pharmacist. This is Zhang Renchong. He lead our team's pharmacometrics study. This is Fan Jing. He is leader our team's bioanalysis. And he also is infectious disease pharmacist. We provide TDM service for 6 major space drugs, especially anti-infective drugs like polymyxin E, daptomycin, tigecycline, vancomycin, linezolid, voriconazole, ceftazidime, and avibactam, amikacin, and meropenem, impenem, and namatrelvir, ritonavir. This is all will provide for ICUs. We provide service for free drug concentration determination for all beta-lactams. We also provide the intracellular drug concentration detection in PBMC, but this is only for research because we don't know how to explain the results about the concentration in PBMC. I think it's really need deeply research. Okay, our TDM service clinical pharmacist will play a role in the teams. The role of clinical pharmacists is provide TDM advice and inform nurse of the requirement for blood sample collecting time. Clinical pharmacists also provide consultation for patients to optimize medication plans and provide pharmaceutical care for patients undergoing TDM implantation. Lab pharmacists need to provide methods for detecting drug concentration and analyze the results together with the clinical pharmacist. The doctor make a decision on whether TDM is needed. Nurses are responsible for collecting blood sample, which is very important, especially as the timing of the blood sample collecting can affect the results of bioanalysis. The wrong time lead the wrong results. So the nurse is very important. Okay, this is our clinical pharmacy laboratory. This is our LC mass and the UPLC. This is other instrumentation like the real-time PCR and microdialysis. This instrumentations to study the pharmacogenomics and the pharmacokinetics. Okay. Let's see the TDM in China. Antibiotics TDM severe in China. We found this study. This study is from the Chinese Clinical Laboratory Center. It's this study tell us the vancomycin and the voriconazole is the mostly commonly used TDM. And for the analyze methods, we can see ALC mass and the HPLC are the majority. So TDM in China is a okay. We can see this paper. This paper is very interesting because they are from the Chinese ICU doctors. They are this Swiss have 3,867 doctors responsible to the surveyors. Through this study, we can learn about the attitude about clinicians towards of TDM. So we can see this number is just the 89%. So we know the TDM in Chinese is very difficult. The doctors don't believe the pharmacist can improve the antibiotics use. And we can find in this this paper about half of hospital in China are unable to provide TDM service for ICUs. This is very bad. And the development of ICU will be limited. So we will promote the TDM together. Another study from Dr. Debbie and Professor Miao Yan compare TDM service in China, Malaysia, and India. The surveys found that China has the largest number of the response, and the TDM for bacteria and antifungals is also the most conducted compared to the other two countries. The top three is vancomycin, norvancomycin. Norvancomycin is a special struggles because no vancomycin just supply on China. So we have no data about norvancomycin and beta-lactams, including the carbapenems and the linezolid. So about the antifungals and fungals such as voriconazole and posaconazole commonly. However, this data is from 3 years ago and may have limitation. The barriers and the challenges for TDM in Asia, I think the first reason is lack of funding or equipment. It's the biggest barriers. And we know there are many developing countries in Asia, some of which are very poor. The gap between the eastern and western of China is relatively large, and the economy of Western China is not good. So in China, the same reason a very TDM developed. But we can see we can see the second reason is lack of interest or cooperation from clinicians. In my opinion, this barriers can still solved by education. There are still many barriers, and I believe education is the most effective solution. Okay, let's see some case. Take a look at two cases. Case one, this is our patient in emergency ICU. He is 72 years old. He residing in nursing home. He has a history of COPD for 40 years, and he has been hospitalized repeatedly due to phenomena, admitted due to phenomena and septic shock, sputum culture, CRKP, cephalidium, avibactam were used for anti-infective therapy. We used 2.5 gram every 8 hours IV drop. Quickly, he was progressed to acute kidney injury. His CRCO only 15.6, and EGFR was appreciated 2.6, 2.7. And at the same time, he development delirium. Why? Because his beta-lactam is too high. Because the AKI, he was supported using the CRT. On the second days of dialysis, his delirium symptoms gradually disappeared. We found the remaining blood sample from his before the dialysis in the laboratory refrigerator. We tested his blood sample. Fortunately, the blood sample was collecting before the next dose of drug infusion. Okay, it's 12 concentration, and found that the concentration of cephalidium was 32.6. The avibactam was 47.1. Is too high. The dosage of cephalidium avibactam was immediately charged to this dosage once daily. Then the blood concentration was monitored again. On the fourth days of CRT, the blood concentration of cephalidium was 31.5, and avibactam was 9.2. It's normal. Okay, this interesting case. The second case is a male, 16 years old, repeated multi-joint swelling and pain for more than 13 years, aggravated with fever for 2 weeks and admitted to the hospital. Previous diagnosis, rheumatoid arthritis. The patient had been take misoprostol for long times, and the physical examination shows multi-lampers throughout the body. After admission, empirical anti-infection treatment with cephalosporin sulbactam, 2 gram every 8 hours IV drop was administered, and with no improve. A consultation request will send to the clinical pharmacist. Okay, we see these lampos are very huge. The multi-lampos are present throughout the body, and the biopsy immediately performed. The lampos is filled with pus that had been extracted. Subsequently, the samples were subjected to microbiologic testing and culture. Okay, the cultural results is positive. Is nocarditis Braziliensis, empirical treatment in reference to Sanford guide should use the impenin plus SMZ. However, considering that this patient is systemical disseminated nocarditis, the concentration of skin and soft tissue need to be considered. So we suggest that the patient use linezolid and linezolid 0.6 gram every 12 hours IV drop for treatment. But 1 week later, he showed decrease in platelets and hemoglobin, which is very concerning for us. TDM is implanted to monitor trough concentration of linezolid. This patient weighed only 38 kilogram and very thin. The trough concentration of linezolid was reported to be 12.8, very high. We optimized the dosage of linezolid and used 0.4 every 12 hours oral. Subsequently, several TDM measurements were performed to determine that the trough concentration of linezolid was below the 8. So his platelets and hemoglobin gradually return the normal. Okay, I will share the 2 cases. I want to see let's work together to promote the TDM in Asia Pacific region. TDM is not commonly implemented in China, but many hospitals cannot implement it. We hope to learn from UQ's experience and also help UQCCR can help us improve our research on TDM in China. We also hope to have an opportunity to continue sharing some work done by our center. Thanks, Hafiz. If you have any question, please contact me. So very thanks.
Thanks, Ben. I'm sure we will have a lot of questions after that talk.